Thank you very much. I'm the third speaker, Rob Martin from the University of Louisville. I'm a professor of surgical oncology and division chief there, and then I run our multidisciplinary hepatopancreatobiliary unit. I became acutely interested in the use of IRE approximately 6 to 7 years ago, again as an adjunctive therapy. I didn't think of this therapy as a replacement to surgery or a replacement to radiation therapy, just because of obviously where I live and work in the United States. Radiation is still embedded in that treatment, but I thought of this as a therapy that potentially could augment the initial responses that we were obviously encouragingly seeing with obviously the triplets and doublets, that being FOLFIRINOX and Gem/Abraxane. Can I go ahead and get my slides? Okay, fantastic. So I am a paid consultant for AngioDynamics, and AngioDynamics, this device is utilized in the United States because of its broad 510K approval for soft tissue ablation. It does not have a specific organ approval in the use in pancreas. I'm going to go over the basics. Obviously, you've talked a little bit about that, but I'm going to go a little bit deeper, specifically into the how do you truly achieve safety and efficacy. That is the key factor in potentially evaluating or even referring patients for this therapy, is to ensure that the therapy is done safely and efficacious. There have been a significant learning curve, and there obviously are even some reports with more significant adverse events, and I'll try and walk you through how we've tried to avoid that. Now, where is pancreatic ablation? Some of you may go, this is just crazy, we've never done it before, and we possibly maybe shouldn't be doing it. Unfortunately, in the literature, it's actually been done, and it's been done obviously clearly over the last 10 to even 15 years, initially starting with radiofrequency ablation with numerous studies, as well as microwave ablation, unfortunately with significant reports of obviously complications, not surprisingly because of the thermal-based modality. Non-thermal-based modalities and SBRT, which is obviously becoming acutely impactful in the United States with the use of both fiducial and non-fiducial based radiation therapy, and then other types of thermal-based modalities, that being HIFU, are continuing to be evaluated. So clearly there is a thirst or interest in how we can potentially accentuate the initial response that systemic chemotherapy gives us. Now, electroporation, for any of you all with any basic science background, is not a new therapy. We know that obviously the ability to reversibly electroporate a cell, we can insert all kinds of things into that cell, proteins, small molecules, DNA vectors, to obviously get them to continue to grow. One of the major side effects or adverse events in a basic science lab is when you irreversibly electroporate that cell, it obviously is not able to repair itself and leads to cell death. It is that type of methodology that we are trying to implement. We want to irreversibly electroporate a core volume with the knowledge that we do get an additional 20 to 30% of reversible zone around that. Now, the key factors with irreversible electroporation is around voltage and amperage. We know that there is a certain threshold of amperage that the tissue will tolerate in order to maintain its non-thermal therapy. We also know that we need to reach a threshold of at least 1,000 volts to permanently, irreversibly electroporate a cell membrane. If you do not reach that threshold, then you are only reversibly electroporating that cell. And thus, it is obviously not going to be long-term therapeutic. The minimum ability to obtain those end results is at least 90 pulses, as was demonstrated, but in a lot of instances, we are having to deliver close to 200 pulses in order to obtain that type of efficacy. Now, there is a technical challenge and a learning curve with the use of IRE. Instead of a single probe insertion like with RFA and even some microwave therapies, this requires very precise multi-probe bracketing of the tumor, but just as importantly, obviously not damaging the vital structures, either bile duct, portal vein, SMV, SMA, hepatic artery, ureter, or other areas outside of the upper abdomen where IRE has been successfully utilized. But the key factor is to avoid any type of repeated needle trauma. That is clearly one of the sources of the adverse events that we have seen, is that with non-image guided needle placement, that leads to a greater degree of multiple needle damage, which can obviously lead to both thrombosis and hemorrhage. Now, the other factors of this is the true method of action. The method of action is clearly electrolyte imbalance. Calcium enters the cell and sodium leaves the cell. That leads to an uncontrolled, obviously apoptotic effect, and the overall efficacy from intact malignant cell membrane to then that immune response to confirming efficacy occurs over an 8 to 10 week period of time. So this is not a rapid method of initial response like we have commonly seen with other thermal ablated modalities. Now for pancreas, what we are talking about, as Dr. Wong has mentioned, is through a small midline laparotomy, assessing surgical resectability both with dissection and ultrasound, and then under precision high definition ultrasound, placing multiple needles that are surrounding the SMA, SMV in this video specifically, and then bracketing that tumor as well as the entire vasculature to make sure that there is a margin of electroporation that is achieved. And then once that margin is achieved, then doing sequential pullbacks based on clearly the perineural and perivascular invasion and the local recurrence rates that can occur. Such treating that you ultimately are treating an approximate 3 to 4 centimeters in a cranial caudal. You're treating close to 3 centimeters in the axial, and then close to 2.7 centimeters in the AP. That's really what I would classify as the sort of sweet spot of permanent irreversible electroporation that can be achieved with 4 precisely placed needles. Now there has been a wealth of literature out there. A lot of it obviously has come from our unit because of our desire to clearly essentially set that foundation of safety and efficacy and the use of this device within patients. We obviously initially utilized this well before we even started our first patient use in chronic animals to truly ensure that we were not going to get any type of vascular thrombosis. We also were acutely aware, because of the non-thermal claim, how hot or what were we seeing any type of rise in temperature. And in this manuscript in the British Journal of Surgery, we do see a rise in temperature when using IRE to approximately 45 to 46 centigrade. It does not reach a thermal threshold, but you do see some outgassing, as Dr. Wong mentioned. Similar to that is the inability to effectively deliver IRE around metal stents or even metal fiducials. Again, as I always explain to my patients, it's like standing in a lightning storm with a golf club. Metal is conductant. It ultimately leads to deflection of the energy and actually reduction in the overall efficacy, and could lead to underlying damage. And then the most recent animal model study that we published last year clearly demonstrates that if you purposely incompletely electroporate the tumor, because of the immune effects that occur and the significant amount of growth factors that occur during that immune modulated response, you have the potential of changing the biology of that remnant disease, and thus potentially upregulating it and making it a more aggressive potential, thus demonstrating why we do not treat patients with visible metastatic disease. And it is the key to why patient selection is critical, to make sure that the entire tumor is treated in that initial session or in subsequent sessions if doing percutaneously in approximate 2 to 3 week period maximum. Clinical data has also been evaluated in regards to both 90-day safety as a propensity matched comparison between chemoradiation therapy alone and or observation and continued chemotherapy versus that tri-modality therapy of chemotherapy, radiation, and IRE, demonstrating an initial benefit. We've worked very, very hard to try and standardize the use of this device to minimize patient morbidity and maximize that patient overall survival with a number of different techniques within that, as well as long-term data, now almost out to 3 years, looking at the safety of treating tumors around vital structures to ensure that obviously narrowing and long-term thrombosis and quality of life changes do not occur. Now you will see that there is very similarity between the algorithms of all 3 of our speakers, and that is not obviously because we all spoke together. But I think we all have a very similar understanding of the biology of this disease. I, too, am very enthusiastic, obviously, with the initial response rates that we get with FOLFIRINOX, and that really is our triple drug of choice because of the flexibility of dose modulation and dose intensities based on our older patients or potentially frailer patients, but also because of the far more robust local response that we do see with FOLFIRINOX that we honestly have not seen as well with gemabraxane. And there is clearly a number of patients who radiologically are locally advanced, who are downsized to then radiologically borderline. And in those patients, we do follow that similar alliance protocol where we also enroll patients in that. And thus we'll use chemoradiation therapy followed by aggressive surgical resections with IRE to accentuate that margin. Since when you look at that data, that margin positivity rate in the patients that were resected is still close to 60 to 70%. So we still believe there is a biologic need to further accentuate that margin even if they have received radiation. If, however, they remain locally advanced, they have unreconstructible venous involvement, bilateral arterial involvement, or extensive involvement that does not require resection, then we also take them on to IRE specifically, restart a Gemzar-based chemotherapy fairly rapidly, and then at 3 months post-IRE, restage, and then use radiation therapy predominantly to cover the regional lymph nodes, not to accentuate the primary tumor, which we have effectively treated with IRE, but the regional lymphatic chain, and then finish with additional chemotherapy for a total of 6 cycles. It is an intensive therapy. By all means, we are self-selecting out potentially the better biologic patients with stage 3. However, 5 or 6 years ago, I don't think anyone would have ever said that, a better biology stage 3 pancreatic cancer. I think there is that degree of optimism that has now occurred with this true trimodality and multidisciplinary therapy that has allowed us to achieve some of the results that I'm going to explain to you. The borderline resectable technique we've also recently published. Fairly simple technique in that it really doesn't change the surgical management in patients with either pancreatic head or pancreatic neck tumors. It predominantly, in this type of case where there's clearly abutment and most likely going to require a portal vein resection, but it is this SMA margin or retroperitoneal margin that is commonly caused that has that high degree of margin positivity. It is at this time before we have done any of the SMV or any of the SMA dissection. And once we have reflected the ligament of Treitz underneath the SMA, we will then place 2 IRE probes, one to the left of the SMA, the other within the uncinate process, to essentially electroporate and obviously further margin accentuate that entire margin. We place them in a caudal to cranial fashion. We run them up the entire length of the SMA, such the goal is to get that approximate 3 to 3.5 centimeters of margin enhancement within that area prior to then doing the dissection. We have also found that even doing this and then following with that dissection and resection approximately 5 to 10 minutes later, it does not make that transection difficult. It only induces some edema, which in most investigators, when we've talked to, actually sometimes can even make that dissection a little bit easier because it softens up some of that very hard fibrotic type of tissue. We obviously do this in conjunction with aggressive pancreatic resections. I think that is vitally important if you are utilizing this in borderline resectable with an overall acceptable outcomes, but most importantly, an improvement in that median overall survival. This paper is approximately 2 years old, and so we've not reevaluated this to see if our overall survival is improved, but that is one of our goals now that this data is approximately 2 years old. If we now switch gears to true locally advanced unresectable tumors based on the radiologic criteria that Professor Rocholima has outlined, and look at that overall outcomes. As he is well established that overall survival still hangs out in the median teens of months, even with best case of chemotherapy and chemoradiation therapy. It goes without saying, though, that with utilizing IRE, it requires a different type of thought process. There is a learning curve, I agree, but there is also a programmatic curve that must occur when utilizing these patients. This is not just a new little device or a new little instrument that we use in the operating room when we feel like it. These are obviously clearly new incurable patients that we've never taken to the operating room before in some units. And there is clearly an amount of pre-planning, but just as importantly, to ensure that high-quality ultrasound and continuous ultrasound targeting is of utmost importance. That is critical to avoid damaging to vital structures. And then most importantly, obviously making sure that the end results at the time of IRE, that change in resistance is reached prior to then removing all of the needles and truly confirming that to be an IRE ablation success. And then very triphasic, obviously high definition follow-up is critical for evaluating local recurrence. There have been a number of overall survival studies, one of which I've already touched on. Professor Naraja's study, which actually looked at these patients, they had indeed included some patients with metastatic disease, which is the reason why their overall survival potentially was less, as well as their lack of using diagnostic laparoscopy, which you have heard. The most recent study came out in January of this year from Columbia University, which did show some fairly alarming grade 3, and I would say alarming, grade 3, grade 4 morbidity, as well as even 90-day mortality. With further evaluation of that data, we came to understand that they were actually placing the needles in an anterior-posterior approach, and thus not utilizing continuous intraoperative ultrasound to guide the needles to ensure that SMV, portal vein, and potentially SMA arterial injury was not occurring prior to the electrical energy. This is of utmost critical to make sure that that needle placement is done atraumatically, such that the energy is then able to do its effectiveness without the added events of that type of mechanical damage and trauma. If we look at our historical paper, which compared chemotherapy and radiation to that trimodality therapy, which came out approximately 2 years ago, we did obviously see that type of encouragement and that obviously improvement in overall survival. But not surprisingly, as many of you all know, when patients recur with locally advanced pancreatic cancer, regardless of the treatment they have, their overall survival after that recurrence is very, very short. It is almost impossible to salvage a patient who is subsequently progressed with locally advanced. There is some encouragement around that, clearly around personalized medicine that we are hearing, but it is still a very challenging problem once a patient progresses to try and improve that patient's overall quality of lifetime after that. It was with that encouragement that we then looked at a much larger series. This was a 7-institution study throughout the United States. This was in a collaborative effort across multiple institutions and multiple surgeons where we had agreed to perform the procedure in a precise manner, utilizing ultrasound, utilizing that cranial caudal needle placement, utilizing similar-based chemotherapies as well as radiation fields, and most importantly, having very, very precise follow-up performed every 3 months for the first 2 years and every 6 months after that to ensure that we could truly capture local irreversible electroporation recurrences as well as distant recurrences. As you can see, once we proceeded with this initial evaluation, we, as obviously the manuscript that came out by Christina Ferrone and MGH and Keith Lillimo's group, found that clearly imaging alone is not as accurate for truly locally advanced. So of these 200 patients that clearly met the radiologic criteria for locally advanced tumors, once we took them to the operating room, 50 of these patients were actually ultimately resectable. Now, I will walk you through the types of procedures that were resectable, but there are some markers as to what patients potentially are resectable to where a CT scan is doing a little bit more volume averaging. And that commonly was in patients with celiac axis arterial involvement alone. Those patients had a much greater chance of undergoing resection, and thus we were using the IRE to accentuate the margin, or patients who had SMA alone. Not surprisingly, if there was obviously any type of venous inclusion that was not reconstructable, majority of those patients were obviously treated with an in situ. So no resection was performed, but the entire tumor was treated. The types of chemotherapies were fairly tight, either a FOLFIRINOX-based or Gemzar-based induction therapy, with the types of pancreatic resections performed in those 50 patients seen here. Again, a US-based study where radiation still plays a role, indicated or not, but it still plays a role in a number of different institutions. Not surprisingly, a small percentage of them did receive radiation, which a much larger percentage going on and receiving those additional cycles of Gemzar-based chemotherapy that I mentioned. If you look at the overall timing, not surprisingly, we do believe in that type of induction therapy, that tincture of time or the ability to assess the biology of the disease. So none of these patients were diagnosed and then went on to IRE. All of these patients were treated with induction chemotherapy. The overall time to perform an in situ-based IRE without any type of resection still hangs at about 3 hours. It still is a tedious, methodical procedure that does require patience, a high degree of image accuracy, and a high degree of image collaboration based on your skill set. You can see for the margin enhancement patients who were resected, the needle placement and the needle energy is obviously much less, because commonly those are only 2 probes that are being placed. Length of stay was comparable across all groups. Clearly there were complications. These are big operations, regardless of whether you're taking out the pancreas or just electroporating it. We did not see any what we would classify as unexpected or unique complications, and a majority of these were similar in regards to patients who are undergoing resection with nausea and dehydration within their 90-day follow-up, liver dysfunction and ascites predominantly around patients with more aggressive vascular disease. We did see some vascular abnormalities, especially in 2 patients who had undergone hepatic arterial resections and reconstructions. We saw 3 90-day mortalities in the in situ group and no 90-day mortalities in the resection group. When we looked at overall survival and followed these patients fairly aggressively, we found that the median overall survival is 25.6 months and a non-significant improvement in overall survival in the patients who underwent resection and IRE, with a difference of 28 versus 23 months in the in situ. When we compared that to established, up-to-date, most recent chemotherapy and radiation, which still median hovers at about 13 months, there is a clear improvement in overall survival with the additive or adjunctive addition of IRE to a multimodality treatment in locally advanced pancreatic cancer. And so because of that and because of that interest, we believe that there is potentially some degree of thirst to continue this type of evaluation. This data that I just presented clearly does not say that it is the standard of care, and I don't stand up here and tell you that. What it means is that we clearly need to standardize its use. It is one of the reasons why that in collaboration with the AHPBA, we have now opened a multi-institutional registry that is truly worldwide. We have been able to be very active in working with all of the HPB societies across the world that are clearly invited to enroll and be part of this working group. Our goal is to make sure that the safety and the utilization of this therapy is of utmost importance, and that bar to achieve these overall outcomes that I've presented continues to be maintained both in single institutions, but just as importantly across other countries outside of the United States. Now, the future directions, I can tell you, are far more robust than the data that we have presented now. I can tell you that IRE alone is just a scratch in the surface as to what we believe we can achieve with this therapy. And what I mean by that is specifically around electrochemotherapy. This is really where I see as the next adjunct, where surgeons will play a huge role in identifying and enhancing drug delivery. As a reminder, this therapy gives us a sphere of irreversible, but it gives us another sphere of approximately 20% larger of a reversible zone. That zone is reversibly porous, which obviously can enhance drug delivery. Our most recent basic science data has confirmed that, which is a publication that is under review and hopefully will be accepted in the Journal of Surgical Oncology, outlining this in a specific mouse model where we obviously created an orthotopic pancreatic adenocarcinoma We randomly selected animals to then receive IRE with gemcitabine, 2 doses almost on top of each other, versus gemcitabine alone. And what you can see here is the significant amount of gemcitabine and its serum metabolites, which were measured by LCMS in that reversible zone. This is actually not the location in the irreversible, but within that reversible zone. The gemcitabine was given through a tail vein injection, thus demonstrating that we are potentially enhancing that type of underlying drug delivery. I would say equally involving of that is because of that effect, we are able to enhance that overall apoptotic effect that occurred a week later when we harvested these animals, clearly that there is a clear synergy between the irreversible electroporation and that drug delivery. I would probably say most encouraging, if any of you all are getting the updates, obviously, from the AACR meeting, is obviously clearly around the immune modulations and what's occurring with that. The method of action of IRE is immune modulated. We know that. There is both a local and a transient systemic response that does occur with the overall cell death and that underlying phagocytosis that occurs through macrophages with that. We are actively looking at obviously combining the use of IRE in a potential phase 1 study with a human anti-PD-1 monoclonal antibody to potentially say, can we potentially enhance those effects and thus lead to much longer progression-free survival, both local and distant, in these patients with this very challenging disease. In summary, I do believe that IRE technique has been optimized. It is safe and effective in that appropriate patient selection. Most importantly, though, is that IRE is not a salvage therapy. If you do a massive dissection and after 3 hours find, nope, this is locally advanced, IRE is not going to help you there. And the reason why is you've disrupted the entire tissue planes and there's no way to place those needles. Similarly, it is not effective in patients who have received very high dose radiation therapy, greater than 50/40. Again, the ability for IRE to work is the ability to treat those cells and allow them to repair themselves. If you have given high dose radiation therapy, that reparative effect is blunted or even potentially inhibited. There are multiple keys to sustainability, and we have a very active working group obviously establishing standards in the diagnosis and management of locally advanced pancreatic cancer, regardless of where IRE plays. More importantly, that needle device placement is of utmost critical importance, and then obviously guidelines around post-IRE imaging. Thank you all for your time and attention. I look forward to the next 25 minutes for hopefully a lively discussion.